going to be talking about global health, as Bill mentioned, and I think if you start to approach global health, I actually Googled it the other day, and there's a vast difference in the top three things that come up. There is globalhealth.com that comes up with an insurance company, and then there is globalhealth.gov, which is Obama's initiative, and there's globalhealth.org. So for me, global health is more an approach to health and human rights and trying to raise the level of care for people all over the planet. What I'm going to be speaking about is just what I know. So global health is too large of a topic to cover in 40 minutes. And so most of this talk is going to be experiences from the field, from the ground, places that I've worked. So when I first finished residency at Harbor-UCLA, LA County in Los Angeles, I knew I wanted to work with low-income populations, and I had had a taste of kind of working in resource-poor settings abroad. And I was thinking of applying for infectious disease, but I came to the Department of Medicine at UCSF, and I asked them, can I spend 7 months in San Francisco and 5 months working with partners in health every year? And the Department of Medicine was gracious enough to accept that. And so for the last 4 years, since 2008, I've worked about 5 months in rural Burundi, a few months in Rwanda, India. Me and my wife just got back from a Fulbright where I was working with tribal health organizations in rural India, and I was in Haiti after the earthquake. So kind of splitting my time between San Francisco and some of these settings. I didn't want to inundate you guys with data, so the next 3 slides are brief exposure to the disparities of healthcare and health throughout the world. And in this slide, you can see the lifetime risk of death while giving birth. And in the United States, it's almost unheard of to die giving birth. And if you can look at this, the y-axis, in Burundi, there's a 40 per 1,000 chance of dying while giving birth. That amounts to around a 1 in 20 chance of dying while giving birth in Burundi as a woman. And in Liberia, it's even higher. And it's not necessarily based on GDP per capita. As you can see, Cuba is a relatively poor country, and their maternal deaths is extremely low. This is child mortality. Each bubble represents a country. And if you look at child mortality, where I was working in Burundi, there's a 1 in 5 chance of dying before the age of 5 in Burundi. And the large bubble, which the country I just came back from, India, which has a population of 1.2 billion, within the country there's such disparity. If you go to the upper middle class in India, they live and die mostly like us in the United States, but some of the sections of the parts of the country where I was in, their mortality is extremely high. There's actually a 47% severe malnutrition in children under 5 in India, which is worse than sub-Saharan Africa. And in the United States as well, the difference between Washington, D.C. and a place like Laurel Heights is quite disparate as well. If you know about the story of HIV, this city, San Francisco, has done a tremendous amount in and is very important in the history of HIV in the 1980s. And it's really activists that pushed doctors to put HIV on the map in the 1980s in this city. And for that reason, there's been solidarity between the San Francisco community, a lot of the gay men in San Francisco, and providing care in some of the poorest places on the planet. And so in the spectrum of global health, HIV has a relatively large amount of money. And still, if you look at this slide, in places like Liberia and Burundi, only 20% of the people that should be getting HIV treatment based on international standards are actually getting HIV treatment. So what we're working on at UCSF and in my work is really implementation. There's a whole host of known therapies that are effective that we still are unable to get to the populations that need them most. And in this slide, 10 or 15 years ago, global health was suffering from a complete lack of funding. And over the last, maybe since 2000, there's been a tremendous amount of money in global health. So it's no longer, it is one hurdle, but it's no longer the only or main hurdle. I was talking to a doctor in the south of India in rural Tamil Nadu, and they work in a small village, and they've been working there for 20 years. And he was saying over the last several years, now it's human resources, health systems, being able to deliver care that they have the money to obtain, the essential medicines that they now have the possibility to obtain, but they're always busy clinically treating patients that a lot of times they don't have the infrastructure and the human resources to step back and improve the delivery of care. This is what mostly I'm focused on. In global health, you can be a researcher, and there's kind of a well-traversed path of having point-of-care technologies, vaccines. All of those are crucially important. But there's another aspect of delivery. How do you get needed medicines, needed interventions to populations that deserve it and are suffering from diseases that we've been able to treat since the 19th century? So this is a quote from the co-founder of Partners in Health. If you're diagnosed with diabetes in a developing country, you die because you don't have insulin. But there's no reason we can't have refrigerated insulin. They have Coca-Cola. And the place that I was working in, Burundi, you could walk for about 10 minutes on an unpaved road, and there would be almost nothing in the vicinity, but there'd be a little shop with a little refrigerator, and inside there'd be Coca-Cola. And Coca-Cola has figured out how to deliver over and over again to the most remote places on the planet, but we are we're trying to figure out how do we do that effectively, consistently, with things that are, much more important than a soft drink. Most of the physicians that I met on the Fulbright in the last several months, and most of the providers at Partners in Health, we all have been trained as thinking about health care, as thinking about how do you intervene on one patient, one disease. And the more you're in the field, the more you start thinking about health as opposed to only health care. And you broaden your vision of what is necessary to keep a patient healthy and a community healthy. So the social determinants of health, which are not really focused upon that much in medical school, is crucial. And it's obvious, but it is still crucial. The circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. Where people are in the social hierarchy affects the conditions in which they live and affect their vulnerability to ill health and the consequences of ill health. These circumstances are in turn shaped by economics, social policies, and politics. So this is a slide also about the social determinants of health, where you can see that many things go to keeping a community healthy, many things go to keeping a single individual healthy. And most of the organizations that I've worked with, you start out with treating, say, tuberculosis, but you realize if you have a patient who is hungry and has tuberculosis, you better start providing food as well as TB treatment if you want them to do well. If they can't get to the clinic, you have to start thinking about transportation to get them to the hospital, to get them to the clinic. Otherwise, you're missing a lot of the struggle and the purpose of trying to keep a community healthy. And even though this is obvious, a lot of times as organizations and healthcare providers, we're in silos where we're treating HIV, but food or housing is not really our issue. And most of the doctors that I've worked with, and what I strive to be, is start thinking about health extremely broadly to address the root cause. So this poem breaks it down, I think, very well. It's Bertolt Brecht, A Worker's Speech to a Doctor. When we come to you, our rags are torn off of us, and you listen all over our naked body as to the cause of our illness. One glance at our rags would tell you more. It is the same cause that wears out our bodies and our clothes. The pain in our shoulder comes, you say, from the damp, and this is also the reason for the stain on the wall of our flat. So tell us, where does the damp come from? And I think the work as a physician, Virchow said that physicians are the natural attorneys to the poor, for the poor. And I think addressing the damp, the disease and the damp, is crucial. So some of the lessons working in the field for now 4 or 5 years, when I started and being a Indian medical student, the kind of push from the Indian community is sometimes prestige and how deep can you specialize? Can you become a cardiologist that's at UCSF or New York? And a lot of times the argument is that if you go to remote places, you'll be treating coughs and colds. You'll be kind of without any technology. You'll basically be handing out Tylenol to these patients. And so I think most of us that work in these settings really realize that we're both socially challenged, but also very much medically challenged. And the other lesson is people who decide what the poor should get are usually not poor. And in one example, in the organization I worked in Central India, they had started with what all of us do is wear white coats in our hospitals in the big cities. And they had started an organization where in 1992, they were walking around and they worked in a tribal community and they all had white coats. And none of the patients, nobody from the tribal community was actually seeking care. Maybe some people from the villages, the lower caste patients would come in because they had seen doctors with white coats. But the tribal community just did not seek care at all. And finally, somebody sat down with the tribal community and started to understand the community. And the tribals said, the Adivasi said that when you wear white coats, we usually cover our dead with white. And why would we go to a hospital where everybody, the healers, are all wearing white coats? And it's one example of what the poor should get is not decided by them. And it's the same a lot of times for essential medicines. It's the same for this notion of preventative care for poor communities, but high-level tertiary care in wealthier communities. So if you're a physician that is practicing in two parts of the world, it's very difficult to offer one level of service in San Francisco at Mount Zion, where I work today, and another level of care for rural Burundi, rural India. And I think most of the providers that I've worked with are really striving to bridge that gap where another type of health and healthcare is possible. This is a patient in rural Burundi where I was working with the organization Village HealthWorks in 2009. And this man's name is Frederick. We actually got approval to show these slides from the patients themselves. And when we found him in his hut in rural Burundi, he was extremely sick. He had stooled all over himself, and his family had left him in the corner of his room to die because they felt like there's no hope for treatment. And the physician from our organization and Dr. Molino picked him up, brought him to our hospital, and this is what he looked like 3 months later. And he had HIV, pretty much very far advanced AIDS, but with a cocktail that was very expensive in 2000. With the work of Partners in Health, we've really been able to bring down that cost, and with simple health systems, successful, proven therapies, these patients can thrive. And Frederick actually went back to his home to visit his family after a couple months, and his wife and his children started to run away from him because they thought he was a ghost, because at that point they didn't believe that somebody that was that sick could actually survive. This is a 12-year-old boy. He actually probably looks a lot younger, and I saw him also in Burundi, and he had a belly full of fluid, and we were trying to come up with what the potential diagnosis could be, and there was a few things on our differential, and we ended up draining draining fluid from his belly and starting him on TB treatment. And this is him a couple months later. So he was actually living in a crowded house with his grandfather with 5 or 6 people. So if you're going to treat a community for tuberculosis, you have to start thinking about overcrowded housing and the root causes of tuberculosis in that community. This is another one of our patients in Burundi, and over the course of my time there, which is just a small chunk of time, it was 5 months, there was several children that came in like this, and with a health system that is not that advanced and some training amongst the health workers and the nurses, you can really come up with a robust effort to treat malnutrition. And one of the doctors that I met in India, he would say that malnutrition is a medicalization of what is actually just hunger. And so he would always say, call malnutrition for what it is, and it's acute hunger. And in a few months, he started to look like this, and he went home. The last few slides that I spoke about is not to kind of glorify my effort or an American effort. I think a lot of times we can talk about our work in a vacuum, and actually the people that are doing most of the work in these communities are the frontline community health workers, the nurses, and this doctor here, Dr. Molino, who day in, day out, with very little resources, accomplishes a whole lot of good. And actually, when I came back from Haiti from the 2010 earthquake, I was asked to speak in a few places, and a lot of times you would go to speak alongside somebody else, and it would be almost an ahistorical analysis of what has happened in a certain country. So we had such an amazing volunteer effort in Haiti, but a lot of times we would go there and not know the history of Haiti, not know kind of the US involvement in parts of these worlds. And you would come back thinking, the government or the leadership is corrupt, but a much deeper analysis in every community that I've ever worked in, there has been amazing members of that community that have worked on these problems for several years, and we're really piggybacking on their efforts. The man in the right-hand corner, the top right-hand corner of the slide is a man named Claude, and he would drive us every week from the capital city in Bujumbura to the clinic where we worked in Kigutu, which was up on a hill. It's a beautiful hill in Burundi. And the road was very unpaved. It took about 3 hours. And he dropped me off at the airport before I left to Burundi, before I left back to the States. And I gave him a hug, and I promised to try to look for shoes for his daughters. A week later, he was doing what he always does. It was driving the team of doctors and nurses and community health workers back from the capital city where they spent the weekend to the clinic in Kigutu, and their truck was ambushed, and Claude was murdered. And for 5 months, it was always Claude, me, and Molino that would sit in the front seat. And when the car was ambushed, Molino was covered with blood, and another person in the back got grazed with a bullet. And he sent me an email that said, maybe a week later, that said, I don't know if I feel really safe here, but within 2 weeks, the clinic was opened again, and he said that when the misery that causes somebody to kill, good health workers and a good man like Claude, when misery wants to spread, we need to spread hope as well. And so he was back and set up the clinic within 2 weeks, and the idea of health is hope, and the fact that in a lot of these places, when you start to see people recovering from very treatable diseases, it's a sign of hope for the community, and it really spreads fast as well. So as I said, really the front line is these, in this case, tribal health workers that in rural Tamil Nadu, in a place called Sitalingi, it's the Tribal Health Initiative. There's 2 physicians that went out there. They just found a map with what is the absolute poorest place in Tamil Nadu, and they decided after they were done with medical school, these are exceptionally well-trained people, where are we going to set up our work? And they went to this rural village, which is 95% tribal, and set up their hospital. And at first, they would just sit in their hospital, and it was just being built, and they would just talk to a couple of people that trickled in and talk to them about their health needs. And they made a commitment to start training the women of the community, and most of these women were illiterate, but they made a commitment to start training these women. And now they have a whole cohort of women that are out there in the community really providing the front line of care. This is a woman on the left-hand side that's doing an ultrasound on a pregnant woman, and then another home visit looking at children. It's a quote by Lao Tzu go to the people, live with them, learn from them, love them, start with what they know, build with what they have. And a whole generation of physicians in India, because me and my wife were on this Fulbright, we're going to spots all over India where there's been doctors working in very poor communities for 20, 25 years. And a whole generation of Indian physicians took this creed very seriously. And this is one among them, Dr. Binayak Sen, who's something like a legend in India. He was actually put in prison for his health and human rights work a couple of years ago by the Indian government. And he started as a pediatrician. And if you would have looked for him when he was my age, he was sleeping in a mud hut in a miner's town in the middle of central India. And he took this creed of going to workers' communities and working alongside them and starting with what they know. And his expansion of what it meant to be a pediatrician extended to the point where there was a government program to train some of the local Indian youth and arm them with guns and try to fight the Maoist rebels in rural Chhattisgarh, which is central India. And so he wrote a health and human rights report to defend those boys against being killed. So he thought if he's a pediatrician, health extends to even government recruiting of boys that are going to die in an illegitimate war. So really most of the grassroots doctors that I strive to be like really expand the definition of what it means to be a healthcare provider. And these are the two physicians in Sithalingi in Tamil Nadu, and they've been there for 22 years. And when they start thinking about health, they started just in 2006 organic farming initiative. And many of his donors always ask him, what the heck can organic farming have to do with health? And so he can't get funding for his organic farming initiative, but he started to notice as he started treating a lot of the men with tuberculosis that most of them were migrating to different parts of the country to get jobs, to work. They were all migrant laborers, and they would leave their village because there was no opportunity to make enough money. And so he started this organic farming initiative to reduce the amount of migrant labor and in turn address the amount of tuberculosis in the community. So for him, organic farming is very much tied to being a healthcare provider. This is another organization that I worked with in central India, and this is actually groundbreaking research in 1997, I believe, where the World Health Organization says if a newborn baby is sick in a very rural, poor community, you have to get them to a hospital. There's not much else you can do. There's not much other interventions that you should try to intervene upon. It's either get them to a place with a neonatal intensive care unit or watch them die. And they started this program with the tribal women of their village, where the tribal women were largely illiterate, but they came up with these beads where they would just count the number of breaths that a baby had in a minute, or not even in a minute. They would have a watch, and they would just notice how much the baby breathed in 1 minute. And for every 10 breaths, they just moved one bead over to the right. And they couldn't count to 50, but when that fifth bead went to the right, they knew that they had to give an injection of antibiotic. And just doing that for neonatal mortality, they dropped, you can see the slide on the left, is that they halved the amount of children that were dying in the first 7 days of life in their community. So what are we doing now? One of my colleagues is actually the person that I started this fellowship in global health and hospital medicine is in the crowd, Fook, and both of us are trying to bear witness to a lot of the struggle that's going on in poor communities around the globe. And really our work is health systems strengthening, improving the quality of care, bringing interventions that have long proven to be successful, capacity building with our Haitian providers and our Liberian providers. We've started with 2 organizations, one in Haiti, one in Liberia. They both work with the public sector. They both build on the public infrastructure, both organizations. In Haiti, it's the well-known Partners in Health, and in Liberia, it's Tieteen Health, which also works in rural Liberia with the government. And so this is kind of our small attempt at health and human rights and improving the quality of care. Since this series is titled Compassionate Service, I thought I would end with some of the things that I've learned about spirituality and service in the work that I do. And I think that the same tenets of being somebody who's attempting to walk a spiritual path is the same tenets that go into doing this work in poor communities around the world. And it's coming from a place of humility and listening. And more often than not, there's much more questions than there are answers. And I also believe this idea that I'm also a meditator, not as often as probably I should be, but this idea that when you're meditating, the only thing that you can learn is through kind of the framework of your body. So you have to do the work of sitting, of meditating, in order to walk on the spiritual path. There's no kind of way around it. And the same thing is true, I think, for work in these communities. I think the learning often happens by being in the field, working alongside these communities. It's experiential wisdom. You can read about how to swim, you can read about how to do surgery, but unless you're actually doing it, unless you're actually meditating, that experiential wisdom doesn't arise. And the last thing is to not look away, and whether it's in terms of your own personal defects or from physical suffering around you, is to bear witness and to not look away. And I thought I'd close with a poem that I wrote while I was in Burundi. And I think if you see this, if you do this work, I think many of us have our own process in kind of learning from it and asking, what our purpose in this work is, and trying to make sense of some of the things we see. So this poem is kind of one of my attempts at process. Right now, the sky cracked open and rain flowed fast into every crevice on the red African mud. The gray sky caught its breath like a child before crying again all the day. As we whispered, never again, Daniel, age 6, never again, Nephtar, age 8, never again, Jocelyn, age 32, never again. Between deaths, they seem to die again and again, a cadence before calamity. Today, those that slip silent into the soil are finally mourned right now by the sulky sky. And maybe I was mistaken. Maybe all spring long, the sun setting wasn't actually God turning his back on Burundi altogether.